Chromosomal abnormalities were the first thing noted about cancer as a genetic aberration. In fact, back in the 1950s, the Philadelphia chromosome was the very first thing identified. And so as the field of AML evolved over the decades, at first, the whole field was focused on these chromosomal abnormalities. And there were a few subsets that were identified favorable risk, but for the most part, having these things was a bad thing. But we didn't really know what to do about it. It didn't offer any new opportunities to target. Now we're in an era where we're looking at specific gene mutations, and that's driving the development of targeted therapies. And we've kind of neglected the chromosomal abnormalities. But 20% of my newly diagnosed AML patients at my institution, literally 20%, constitute the group that we refer to as a TP53 mutated complex karyotype, a very specific, distinct phenotype. And I think people have been approaching that disease in the wrong way. They've been focusing on TP53, but the TP53 mutation just allows the loss of genetic integrity. You get a TP53 mutation, you might get a mutation that's not so terrible, like an IDH or an NPM1. Those are curable patients. More commonly, you get back to those chromosomal abnormalities, multiple ones. Damage already done. When the patient presents multiple chromosomal abnormalities, and everybody's going back and looking at TP53, too late. The horse is out of the barn, and shutting the door at TP53 is not going to help all those chromosomal abnormalities. So we now have to start focusing on that work. I think we have the ability to do it. We really need to carefully look at those patterns. What's driving that subset? It's utterly different. So we're almost back to the era of cytogenetics being so crucial again.